We have a large muscular artery, just kind of based on the context clues, probably going for temporal arteritis. It's the temporal artery.
Because we know, for anyone who's new watching this, we would never cut a specimen like this otherwise. When they send us a temporal artery biopsy, we cut it up in cross section and then embed it very carefully so you can see multiple cross sections in the same slide. And then we hunt diligently for temporal arteritis, and we often do not find it, as Dr. Pitch very nicely pointed out. These are sometimes frustrating and agonizing specimens because they take a long time looking very carefully. But not this one, huh?
No, this one's great. There's kind of like a circumferential rim of lymphocytic, maybe some histiocytes, like an inflammatory infiltrate kind of around and intramurally also. So yeah, this would be great for temporal arteritis.
Yeah, very good. Yes, the muscular artery here, the temporal artery, we can see there's a little bit of elastic lamina here. Much easier to see this on a regular light microscope where you can flip the condenser back and forth to see the refractile lamina, but the lamina is being destroyed by this inflammatory infiltrate that's actually destroying the muscular wall, and the intima has even got a ton of reactive change in here. And there's a lot of lymphocytes and histiocytes, and if we hunt around, we will probably find some giant cells. But in the setting of a patient with, headaches, jaw pain, vision disturbance or loss, where there's a clinical concern for temporal arteritis, and they do a biopsy, and usually they're going to have elevated ESR, erythrocyte sedimentation rate, and C-reactive protein, because there's an inflammatory process. In this context, even if I find a little focal bit of lymphocytes or histiocytes in the wall of the vessel without giant cells, that's very concerning for giant cell arteritis if you see it. And then right here is a giant cell. You may have to hunt around for a while to find a giant cell, but this case is florid, rip-roaring. A lot of times we don't see this because the patients, as soon as they present and there's clinical concern, they give them high-dose corticosteroids, which will wipe out the inflammation. And so when we see it, we may see a big zonal scarring, loss of the elastic lamina and scarring of the muscle wall of the vessel, but we will often not see any inflammation. And I have learned over time that you will often see little tiny foci of disrupted elastic lamina, but when we've sent those cases to eye pathology experts, they've said, yeah, focal loss is not a big deal. What you want to see is either obvious active arteritis like this, or in a treated case, like big zones where the elastic lamina is lost and there's scarring, fibrosis in the wall of the vessel. But when it's obvious like this, no problem. This is giant cell arteritis, temporal arteritis. In other treated settings, I personally find those very nuanced and challenging to interpret in real life, and often a struggle. And for a long time, I didn't really understand why, since the patients had already been treated, what was so important about knowing it. But from talking to some of the treating physicians, they said that the real question is if we think there's no arteritis, then they'll take this patient off of steroids. Whereas if the patient has arteritis, they will often leave them on steroids for a longer course. And as we all know, high-dose corticosteroids are powerful drugs that can do great things, but also come with a lot of side effects that can be quite serious sometimes. So that's the significance. But if you have any doubt, find your local friendly ophthalmic pathologist, and they often have a lot of experience in dealing with these. But yeah, this one is a really florid example. And you can even see like fibrinoid necrosis sometimes in the vessel wall. And sometimes I'll see neutrophils with it even. And the giant cells, like we've looked at multiple sections, but only seen a couple of giant cells. And they tend to be, the giant cells and histiocytes tend to be hanging out right there around the edge where the intima meets the muscular media, where the elastic lamina is. So they tend to kind of be wrapping around that. And we usually have to examine multiple deeper sections on these in subtle cases. In this one, one section has got a slam dunk diagnosis for us.